DCRI Research Conference. I recognize we're competing with Chancellor Washington's visit with the DCRI, so I'm glad that this is going to be recorded. Jeff has not taken any personal offense to the group here, and to those viewing, hopefully you got a chance to catch up. This is really a nice treat to be able to have Dr. Clough present. He's one of our newer faculty members. He's a general internist and health services researcher in the Center for Pragmatic Health Systems Research and an assistant professor in the Department of Medicine. Jeff's research focus primarily is on developing and evaluating novel approaches to financing and delivering healthcare, particularly in the outpatient setting. He completed his undergraduate at Princeton University, followed by an MD at Jefferson Medical College, during which time he also earned an MBA. He then came to Duke for his internal medicine residency, and then left to work at the Centers for Medicare and Medicaid Services Innovation Center, where he helped develop and launch several innovative payment and delivery models. This included leadership of the $1.4 billion Healthcare Innovation Awards Program, which has provided support to over 140 innovation delivery models. After 3 years at CMMI, he returned to Duke and joined the DCRI last year. And today we get to hear from him and his personal experience on how to improve value through alternative payment models. So thanks for joining us, Jeff.
All right, thank you. I'll try to use this, I suppose. All right, well, thank you very much for having me today. This is going to be kind of a blend of my prior life in the policy world and current work we're doing and trying to build here as a researcher. So the stated objectives of today's talk were to provide some background information on some of the major efforts going on out there in the public and private sector around alternative payment models, to describe really a lot of the experience at this point and some of the evidence that exists around these payment models. But then also to talk a little bit about, at least what I see are some of the key research needs and opportunities, and highlighting in particular some of the work that we're doing. So first, just to start with a couple of basic definitions, what is an alternative payment model? I think this term, really a lot of the work around alternative payment models started in 2010 with the Affordable Care Act. This term really became very popular in the last couple of years, perhaps most prominently at the beginning in 2015. The Secretary of the Department of Health and Human Services, Secretary Burwell, made an announcement that they're going to try to move 30% of traditional Medicare payments into alternative payment models by the end of this year, and 50% by the end of 2018. And the definition they've used, it's actually up on CMS's website, it's a little bit clunky. It comes from a JAMA Perspective article authored the year before by some CMS leaders. Some payment is linked to the effective management of a population or an episode of care. Payment still triggered by delivery of service, but opportunities for shared savings or two-sided risk. That's not really clear. That's okay. They've listed as examples of existing alternative payment models, and those basically include accountable care organizations, medical homes, and bundled payments. And I'm going to go ahead and just focus my talk around those three models, and I'll explain what they are in a little bit. Shortly thereafter, just a few months later, historic legislation was passed with really widespread support from both parties in Congress. It was and from the provider community, and it was really most exciting. Sort of the policy bane of physicians' existence has been this sustainable growth rate present since the late 1990s, which was basically enacted to cut physician payments from Medicare if overall spending was growing too fast. And of course it was, and every year Congress had delayed enacting that policy but wasn't able to really come up with enough funding to get rid of it. So it was finally abolished in 2015, but in its place they set up a system where beginning in 2019, physicians are basically going to have to choose to either have a lot of their business in alternative payment models, or they're going to have to participate in this kind of souped up pay-for-performance system that's yet to be designed. And in that legislation, so they gave us these examples of, these are the things that count as alternative payment models, which include the new models that are designed by my old office, the Innovation Center, as well as the Medicare Shared Savings Program, which is an accountable care organization program. They kind of, at least for the purpose of this talk and kind of the current state, again, it's basically accountable care organizations, medical homes, and bundled payments. And I won't we'll ask you not to think too hard about whether that really has a unifying definition or meets the previously stated definition of an alternative payment model. So to just take a pause, and I think we have to, why is this happening? Why is everybody so excited to drive the world into alternative payment models? Have there been great randomized studies, touting alternative payment models as a panacea to improve our healthcare system? I think at the end of this lecture, you'll see that it's a resounding no. There are a couple of quotes up there from some of the key stakeholders about, why, to kind of give a sense of why people are gung-ho about alternative payment models. Oftentimes, the rhetoric tends to focus on the potential for alternative payment models to improve the quality of care, to support providers, allow them to deliver care in new ways. Generally, the idea behind alternative payment models is in contrast to the fee-for-service system, which is the current state, the alternative we're moving away from. Rather than only reimbursing for very specific services, it gives providers a little more flexibility to achieve outcomes, take on more of that risk. In theory, it allows for a lot of innovative models. I think if we were going to try to just build the case that alternative payment models are going to continue to come into being, and we're going to see a lot of enthusiasm based solely on their ability to improve quality, you might be very skeptical and even wonder if it's worth building a research program around. I think kind of the other side of it is, alternative payment model. The real wind in the sails of the alternative payment model movement is that we have a major problem with the cost of healthcare in this country, and despite what evidence exists, it seems to be the most desirable option at the moment as compared to other policies that have either been enacted or proposed that usually include kind of across-the-board payment cuts, reductions in benefits, reductions in eligibility. The idea is the alternative payment model puts more of this in the hands of actual providers to help identify ways to really cut costs while either improving or at least maintaining the quality of care. And just have a couple of these budget type slides to help make that point. And admittedly, I'm going to focus a little bit more on the Medicare population. I don't want to kind of minimize the financial problems that other major payers in this country face, but they're a little bit more challenging to present succinctly. But also Medicare has really been the driver of the alternative payment model movement. Most of the major programs that are out there are being driven by Medicare, and so sort of Medicare's needs are, I think, essential to building the case around alternative payment models. So this just taken from last year's Congressional Budget Office projections, some basic data looking at the federal budget projections. That line represents what we take in taxes, and the major bars are how the federal government spends its money. As you can see, 2045 sounds like a long ways off, but this is kind of the period during which many of us will be delivering care or part of a system that's delivering care or drawing down benefits. Really what you can see is there's a growth in a lot of the main areas where the government spends money. Certainly Medicare, that second bar from the bottom, is a high growth area, as well as just above that, the Medicaid and the commercial sector portion of the federal budget, and then net interest on the debt. I mean, really those are kind of, there's not a lot here to take money out of. So I think it's, at least in my view, it's fair to say there's going to be continued pressure to try and keep healthcare costs down, specifically Medicare costs. And just a couple quick slides to kind of help us understand that. On the left, over the last 7 years, that shows how costs have been growing for the three major payers. Again, pretty comparable. But if we actually decompose the drivers of that cost, I think the graph on the bottom right is perhaps most important for each year, looking from left to right, commercial, Medicare, and Medicaid. The main drivers of growth, particularly for Medicare and as well for Medicaid, are really more people coming into the system. And unlike in the commercial sector, where the same people that are paying into the system are drawing out from the system, in the federal programs, you have a different set of people who are paying the premiums, essentially, and those that are drawing down benefits. And Medicare's woes aren't really driven by sort of poorly managed system, rapid cost growth per person. It's just more people coming into the program. And then just finally, to make that point more bluntly, this looks at, this is essentially the number of people drawing benefits out of the Medicare program the ratio of that versus the number of, it's actually the ratio of the number of workers paying into the program compared to per person drawing out. And we're kind of in this downslope period right now where we're moving from a time when there were historically around 4 workers per beneficiary to close to 2 workers per beneficiary. And that's really kind of the fundamental issue, something we can't really correct, that's going to continue to drive the concerns around healthcare costs. So all that is to kind of make a summary point that, the real battle we're facing is trying to preserve these important programs that so many of our patients rely on to receive even an adequate level of care. And we need to do something, and at least at the moment, alternative payment models are something that many of us are interested in hoping will be effective. All right, so now I'm going to dive into talking a little bit about what alternative payment models are out there and what evidence exists to date. I'm going to start with accountable care organizations. This is kind of, at the moment, I think kind of at the leading edge of the alternative payment models, certainly the biggest program and based on a number of metrics. The definition of an accountable care organization is it's basically essentially a group of providers, often physicians, hospitals, really can be any permutation that agrees to collectively be accountable for a assigned group of beneficiaries and just accountable for everything. So usually it's just all of the medical care that's delivered during a year. And the way these contracts work, and at least certainly the way they work in the Medicare population, is basically the ACO contracts with the payer, and the nature of the contract is that the ACO needs to meet some quality metrics to be eligible for a payment. But if they're able to hold total costs between an expected amount, they get to keep a portion of those costs. They can basically finance their activities to meet the goals of the program. It's basically an outcome-based payment. All right, and then just to show a little bit about how accountable care organizations have grown over the last few years. I'll start with the top kind of, I guess, olive green bar there represents everything outside of Medicare. And these are tracked a little bit. There are a couple of consulting firms out there that through a variety of mechanisms try to keep tabs on how many contracts are out there in the commercial market. I will say that we don't have much information about the nature of these contracts other than they call themselves ACOs, so it's a little bit more nebulous. The remaining bars are all Medicare ACO programs. And we know a lot about these programs because their parameters are public knowledge. There's a lot of information and data that can be obtained. On the far left is actually the physician group practice demonstration. This wasn't technically labeled an ACO demonstration because the term hadn't come into existence at that time, but it's a program that Medicare ran that looks very much like it probably would be called an ACO program today and was actually formed the basis of the structure of these other programs. And then beginning in 2012, the MSSP is the Medicare Shared Savings Program. This was specifically legislated in the Affordable Care Act. That started and has grown pretty quickly over the first couple of years and leveled off a bit in the last few years. That little small kind of, I guess, teal bar there is the Pioneer ACO program that's been run by the Innovation Center. It's essentially a variation on the Medicare Shared Savings Program. It's a little bit risk, a little bit more reward for participants. Starting this year, there are a couple more flavors of ACOs. There's an end-stage renal-focused ACO, and then there's the Next Generation ACO, which is sort of an evolution beyond the Pioneer ACO program. Actually, 3 of the 21 Next Generation ACOs are in North Carolina, so there's a little bit more geographic diversity with that one. And I think there's close to 8 million Medicare beneficiaries. I think it's around 15% of the Medicare population that are in one of these ACOs at this point. So what do we know? First concentrating on the peer-reviewed literature where we have the best knowledge about what's happening here. Back to the physician group practice demonstration, a group at Dartmouth has done most of the evaluation there. There were several studies. Kind of the bottom line evidence was that overall it did seem to be associated with pretty modest savings, mostly among beneficiaries who are Medicaid and Medicare eligible, tend to be thought of as some of the sickest beneficiaries. A couple of specific analyses looking at cancer services and cardiovascular services found real no association with change in that program. And then a couple of articles that received a lot of attention last year. focusing on the Pioneer ACO program, again, has shown some small savings, a group at Harvard and then a group at CMS itself. In the first 2 years of the program, largely coming from hospitalizations, which is an area that we think a lot of ACOs are focusing on. But that's pretty much it. I think there are a few kind of glaring points here. One, we know very little about the biggest ACO program out there. CMS does release information basically stating how many ACOs achieved shared savings against the contract, and it's been a pretty modest amount. But we don't have the same kind of rigorous evaluation to understand what's happening. And again, I think a couple other issues. A lot of these have looked at kind of the summary impact of the program, but we don't know a lot about what providers are actually doing within the ACOs. There's a ton of heterogeneity even within these small programs themselves. And of course, a generalizability issue. The Pioneer ACOs were handpicked, thought to be kind of more advanced systems than the rest of the country. So it's very hard to generalize, both to different providers, but even to generalize those results to new and evolving programs, I think it's very challenging. So in summary, we don't know a lot. On the commercial side, most of what we know in the peer-reviewed literature comes from several studies out of Harvard that have mostly looked at this one ACO contract, the alternative quality contract between Blue Cross Blue Shield of Massachusetts and a handful of provider groups. And I think, in summary, kind of over several years, there do, again, seem to be some modest savings coming from that. Somewhat in contrast to the Medicare population, the commercial population, one can achieve some savings by shifting to less expensive providers. In the Medicare, where Medicare sets the prices, you largely have to actually change utilization to generate savings. But there is some modest impact. But again, it's a very small sliver of the commercial ACO population. We know very, very little about what else is happening. All right, so to move on to kind of the second big alternative payment model that's out there, medical homes. It's interesting, the medical home is really not a payment model, it's really a delivery model, but it's often has been given example as a payment model. And it's actually kind of a heterogeneous group of delivery models which at their core generally include some enhanced services or capabilities at primary care practices, although the definition has been applied in a variety of terms. But typically it's accompanied by a payment model, which usually includes a capitated fee per patient per month for doing whatever services the payer and the providers agree should be part of the model. And increasingly it includes an outcomes-based payment. It could be in the form of a shared savings, much like the ACO programs. And there are a lot of different pilots out there. Oftentimes there are commercial and public pilots combined. A review done by researchers here at Duke a couple of years ago, a systematic review of the medical homes, basically found that overall there have kind of been some small gains in various aspects that reflect the quality of care, although no net cost savings or really significant reduction in patient use, and of course is limited by the variety of programs that are out there. So I know that's not maybe real reassuring for this type of model. I will say probably the biggest medical home model out there to keep our eye on is, again, the Innovation Center's Comprehensive Primary Care Initiative. And a few reasons I say that. One, this is multi-payer, so the way it worked is first CMS went out and got payers to agree to participate in the model and to contribute money alongside of CMS. So the idea would be that you'd have a critical mass that you could actually drive behavior change at the physician practice level. It's large, there are nearly 500 practices in 7 different states or markets. And it actually has a larger dose than many of the previous medical home models. So at least for Medicare, they typically pay on the order of $5 per patient per month. This is averaging about $20 per patient per month, which actually works out to be a lot of money for a primary care practice. So there's some real funding to help physicians make changes. That said, thus far, we only have information from the first year of the pilot, which is a CMS commissioned report. It's not actually published in the peer-reviewed literature, but it's CMS contracts with independent evaluators to evaluate its pilot programs. And there were some gross savings in year 1 and kind of some equivocal changes on the quality metrics, but not yet offsetting the care management fee. So we don't yet know if this will evolve and be successful, but it's certainly something to keep our eye on in the near term. And then lastly, the kind of last group of models to go over, the bundled or episode-based payment models. These are really kind of even more variable, I think, kind of to put it in plain language. I mean, it looks very much, it can look very much like an ACO type arrangement, but it's usually for a much more focused set of services, most commonly defined by a clinical condition, or even more commonly by a very specific episode of care. I think far and away the most common type of model we're seeing out there are for hip or knee usually elective hip or knee replacements. There's also a lot of growing interest in oncology-focused models. I will say, I didn't really mention this earlier, but with the new legislation, the MACRA, it actually compels CMS to work with physician groups out there to design new alternative payment models. And the biggest thrust is looking for models that involve other specialties beyond primary care. And so I think, what we've seen so far, most physician groups out there are kind of working on these types of models that are specialty specific. So we may see a range of additional at least focus areas for these types of models in the near future. So what's sort of the state of existence of bundled payments? Well, Medicare's program is by far kind of the largest program at the moment. The Bundled Payments for Care Improvement Initiative, this is what I kind of worked on for my first couple of years at CMMI. There are finally a lot of contracts in place here. It's a set of models. It targets a set of conditions, but they all have in common that they begin with acute hospitalizations. That's usually the defining event, and typically it includes care for about 90 days after the end of that hospitalization. As of 2016, it's a little bit complicated in that organizations can have a contract with CMS and they can actually be working with a variety of providers. But to kind of describe the prevalence of that model, there are over 1,200 different sites that are participating in these contracts and initiating these episodes of care. Most of them have started just pretty recently in the last year or so. Early results, again, from a CMS commissioned evaluation, and it really just focuses on a few sites during their first year of operation. It has shown some savings overall, mostly by reducing the use of recovery care following a hospitalization. We know that there's a lot of variation in the cost and even kind of the modality of recovery care following hospitalization. So that's seen as a big opportunity. So again, it's some promising changes here, but we don't have a lot of information. Some point in the near future, CMS should release the next year of evaluation. We'll have a little bit more data to look at. And then I think what's really interesting and has really grabbed a lot of attention this last year, CMS announced that it's going to implement a mandatory comprehensive joint replacement model that begins this year. And it's structured very much like that model, focusing just on hip and knee replacements, but they're actually going to require 800 hospitals to participate in that model to basically assume accountability for the episode of care. And the Duke hospitals are actually in that group. And this is, it's not only novel because it's a large-scale test of of the same type of episode, but it's really the first time that CMS has actually mandated that people participate in these risk-taking models rather than only working with volunteers. So it's definitely receiving a lot of attention. It'll be interesting to see what happens with that model going forward. CMS is also going to be starting an oncology care model this year. I'm not going to go into the details of that, but it's basically testing episode of care payments centered around patients who are receiving anti-cancer therapy and focusing on medical oncologists. And on the commercial side, there's been a lot of talk about episode and bundle payments, but the actual delivery is a little bit more anemic at the moment. The advisory board company does kind of similar work trying to track the number of bundled payment contracts out there. At the moment, they report really just kind of dozens in the commercial sector, and they're just in a lot of, there are radiation therapy focused bundles and the hip and knee replacement bundles. So there's just a lot of heterogeneity. We don't have a lot of details. Really, we know very little about what's going on in the commercial sector. One thing I will say about bundled payments, it definitely seems pretty up in the air right now of even what conditions might go forward. Certainly the joint replacements have a lot of potential because of what CMS is doing. And I've, speaking from experience, I know how complicated it is to set up these arrangements, to make agreements between payers and providers. It may be the case that ultimately, the future of bundled payments isn't so much in payer and provider contracts, but I think at least the episodes of care and kind of the nature of these contracts may end up being used by organizations such as ACOs to help set up arrangements with providers within their own organizations. There's still a lot of potential for this concept to continue in existence. All right, so I think I could probably summarize the evidence to date. There's not a whole lot. We're kind of at a point now where we've gotten through the hard part of getting a lot of contracts set up. So a lot of people are working on these programs. We don't yet know much how they're doing or what they're doing. At least most of the data seems to be pointing slightly in the right direction, even if only modestly. But by no means have these been demonstrated as an effective way to change the delivery of care. But the good news is that means there's a lot of opportunity to do research. And there are kind of three main areas I'm just going to go over. So first, there are opportunities to just kind of continue evaluating these models, to do research in a similar vein that's been done to date, looking at the summary impact of the models. As I've mentioned, there's really been very little evaluation of the biggest program out there, the Medicare Shared Savings Program, other than some of the kind of summary data that CMS releases. We're actually in the process of trying to obtain some complete claims data around the Medicare Shared Savings Program that could support these types of analyses, as well as some of the additional work that I'm going to bring out. And then certainly some of these other emerging models. The CMS will commission official evaluations of these models to look at kind of the summary impact, but there's also lots of opportunities to look at specific aspects related to the programs. And then on the commercial side, that's really pretty wide open. I think there's certainly a lot of interest, not even evaluating the programs, but even understanding what's being done in the commercial sector. That information research in that area is a lot harder to do for a lot of reasons. Getting the data, which is proprietary, getting it from individual plans, and even getting the information about the nature of the contracts themselves can be very challenging. But so maybe a little bit on the back burner at the moment, but certainly an area where there's a big need, and I think there would be a lot of interest for anyone who's able to do that. And so in this sort of realm, in addition to just looking at the overall impact, I think there's a lot of potential for sort of early high impact research, evaluating specific components of the programs that can inform policy changes. I think it's analogous to a lot of the work that's been done around, say, some of the readmissions quality measures, where people have looked at different things, looked at ways maybe the risk adjustment methodology may not be appropriate, or other unintended consequences to inform some of those rapid changes to policy that occur on an annual basis. So like as a couple of examples, thinking about the ACO program, we really don't know if ACOs are attracting more complex patients because they offer better services, or maybe they're trying to kind of push away their more complex patients so that they'll do better under the program. And understanding those types of things can inform a number of elements of the program itself. And then certainly kind of related, CMS has a set way of risk adjusting the benchmarks. Their ACOs come in a lot of different shapes and forms. As an example, Duke is an ACO, and we don't really know if the risk adjustment methodologies used for most kind of general primary care-based ACOs out there work as well for an ACO that's built around a tertiary academic center. And if if through kind of creative ways we can understand, how the arrangement may not be working as it's intended, there's a lot of opportunity to make real important changes to the program, which sound a little wonky, but these are the things that people debate heavily and can make the difference between an organization receiving millions of dollars based on the work they've actually done versus receiving nothing for their efforts. And then sort of a separate vein, and this is admittedly a lot of the research that I've done to date is kind of more traditional health services type research, looking at variations in care, really trying to understand where the opportunities may be. This is just data from a study we published in Health Affairs last year, and it really has helped support the oncology care model. And what we did is we looked at every oncology physician practice in the country using Medicare claims data, and looked at basically the average costs, risk adjusted as best you can do with claims data, per patient for major service categories. And we actually found substantial, really large variation in areas of care that have been identified by clinicians as being potentially low value, wasteful. For instance, some of the drugs we found have been pegged in choosing wisely measures. So it supports that there's probably some provider level differences in patterns of care that could be potentially addressed through alternative payment models. Actually, I have a similar study, and it's cardiology focused, that should be out this week or the next from the Journal of American Heart Association. And so I think there's opportunity to kind of continue identifying those opportunities for alternative payment models. And then kind of, that's looking like across providers, looking at where the opportunities are to implement alternative payment models. But then even within providers, more and more we're understanding that, again, to go to the ACO program, these organizations are now at risk for a broad set of services, but they don't necessarily have the information to know, what might be the best opportunities for them to focus on to implement delivery changes. There's a real need for kind of some useful data that these organizations can use to succeed within the alternative payment models. These are just a couple graphs where we have some internal funding to work on a project to help develop a set of useful information that ACOs could potentially use to understand where some focal opportunities may be and to benchmark themselves against peers. So I think that's an area where we know there's a real need. The participants in these models themselves have said we need this kind of information to be successful. And then what I think is the most interesting area to focus on is what I call just kind of opening the black box, understanding what providers are doing within APMs and really understanding what's actually working within APMs. At a very high level, the way alternative payment models are set up is that the alternative payment model creates an incentive. It creates an incentive for providers to achieve certain outcomes. But in contrast to the fee-for-service system or, say, pay-for-performance types of arrangements where the arrangement prescribes a very specific set of services, the alternative payment model gives providers a lot of flexibility to figure out what they need to do to test and implement different strategies to achieve those outcomes. And a lot of the research that we've seen to date looks at the kind of the association between participating in an alternative payment model and the outcomes, and kind of skips over a lot of the information about what people are actually doing. And that's useful, of course. But of course, some of the limitations are there are a lot of mediating factors that can occur on that pathway, and if we only look at the association, it can be hard to replicate, hard to spread, hard for providers to understand, those who are not being successful to understand what they can do. And so again, this is at a pretty high level. I think what we're really trying to understand is the relationship between what providers do and those outcomes, which is somewhat agnostic to the type of incentive. Understanding how do you actually better organize and deliver care for a population of patients with coronary artery disease or non-small cell lung cancer. What are the specific clinical pathways and things that you do? But the alternative payment models, it gives us an opportunity, kind of a collective group, to do this work. And I think you might say you could kind of do this work outside of the, you could do this work anyway. You could look at systems of care. Generally, kind of the first approach to this discovery is to try and look at systems that are performing well, and then to further delve into that and kind of discover discover their strategies. And I think it's sort of analogous to say what's been done in the past to improve door-to-balloon times at the hospital, et cetera. Looking at those systems that do things really well, and then identifying their specific processes. I think there are two main reasons why the APMs, and really most notably the ACO model, gives us kind of a new opportunity to open new frontiers in that science. The first is that we're working with a group of providers who do have an incentive that non-APM participants don't, to actually improve care that at least meets the outcomes that are part of the APMs, which is generally more efficient care and whichever quality measures are specified in the APMs. So we're working with a group that's likely, it's sort of a group of providers to work on where we're likely to find some real innovation. And of course, they've actually volunteered into these models, so we know that they're the organizations that are, not only have an incentive to work on the problem, but are actively engaged and believe that they're trying to do it. So it's sort of a good area to go looking for these innovations. Another reason it's a little bit more technical, and again focusing on why we're sort of pursuing the ACO data and the ACO groups to do it, is it actually gives us a defined system to look in. So a lot of the work that's kind of, especially like the kind of variation claims-based work that's been done out there, it's either focused at the hospital level because you can define a system based on people that go to the hospital, and that's great for looking at things like readmissions and maybe complications after a procedure. A lot of the other work has looked at regions and looking at broad variation across regions, but of course a region isn't really a system of care, and it's hard, even when you identify large variations across regions, it's hard to figure out what this system provider level modifiable factors are that's driving that variation. The ACOs are really nice because we now have a defined system that we can work with, and we can look at things across that organization, particularly looking for types of delivery changes that are occurring in the outpatient setting, which would otherwise be very difficult to define. And these are organizations that have basically said, these are all our partners. We are together working as a team. These are the beneficiaries that are assigned to us. So we have that link between system and groups of beneficiaries. And just as the types of things we can start to look at, looking at sort of the way, particularly the way like primary care physicians and specialists work together. We know there's like a lot of variation in how patients are managed for common conditions, how often they see specialists, or how often they even go to the primary care physicians for similar decisions. End-of-life care is a major focal point, not just looking at what happens once someone's gone to the hospital near the end of the life, but kind of moving a little bit more upstream and understanding what's happening with people with advanced illness, but before they've triggered sort of a clear defining point. And we expect that there are a lot of system level factors that influence those outcomes. Now we can identify the systems that are maybe achieving better outcomes and try to discover what they're actually doing. So that's the area I think once we have the data and a little bit more adept at doing this and have kind of some initial wins, I think that's an area where we're going to see a lot of opportunity for collaboration. We know certainly people across the center have a lot of ideas and are interested in identifying better ways to deliver care in specific areas. This type of capability basically gives us a vehicle to do that. And so then that's basically the end, just to kind of summarize and recap. Participation in alternative payment models is unequivocally growing. We know that a lot of people are participating. We're still kind of in the early years. We don't have a lot of information even about how they've done, much less how they've done it. But overall, they're at least, and I guess it depends on your perspective. Some have emphasized, well, at least we're seeing a little bit of movement in the right direction. I think others have emphasized that this is far less than what we would have expected at this point. So really hard to say. But I think until a better approach emerges to deal with our problems, at least these are something we're going to probably contend with and see featured as a prominent part of healthcare policy in the near future. But then most importantly, I mean, for me is I got to participate there in the early stages, setting up a lot of these contracts, setting up a lot of the work, and now I think we're in the phase where these things are active, and now it's a really exciting time to kind of do the research, understand what it takes to actually be successful, and really ask the question, how do you deliver high-value care? And APMs are a great context to do that work. And so that's kind of the new challenge at the moment. And with that, I'll stop and pause for questions.
Great. Thanks so much, Jeff. I'll open it up to the audience. Any questions? Yes.
Thanks for a great discussion. Within the concept of shared savings, it seems that if we're really going to see a big change in the overall cost, then the savings should really be affecting key drivers of behavior, both on the payer side and on the provider side. Mm-hmm. And it seems that we're largely talking about revenue right now for the provider, and we're talking about payments to providers on the part of the payer, mm-hmm. and, as opposed to true margin. In other words, we really don't understand what kind of cost savings or cost increases might exist in implementing these systems on either the payer or provider side. Yeah. So I'm curious about your opinion about how these programs can become more robust to the point where margin is the driver on both sides, so that there really are true motivations to moving forward and developing larger implementations.
Yeah, I mean, it's a great point. I mean, we know very little, and I think your point is very important. We don't know what, sort of from the provider perspective, I mean, in addition to the many things we don't know, we certainly don't know what it costs them. And of course, since it's hard to identify which delivery changes are even effective, it would be hard to kind of intelligently even make an estimate. But it's critically important. I mean, I think if you look, from the payer perspective, CMS mostly needs to see that their payments go down. Presumably, providers won't continue to participate in the program if they are in fact reducing revenue, but their costs are in excess of even what they might earn through shared savings. So it's I think it's kind of the consumer of that sort of research tends to be the providers, where not only do they need to know how do they achieve the goals of reducing changing care so that they reduce revenue, and want to make sure that it's at least not to the detriment of quality, but they also want to make sure that it's their business case fits within that. And there's even some opportunity in some of these models where you could implement a change. I think this is the type of thing that the AMA and others highlight, is the idea that these payment models allow more flexibility, where in theory you could make a change in the way you're delivering care, and maybe it's kind of neutral in terms of changing revenues, but it's much less costly to you because you're using different providers, or like the bundle payments model is a good example, where a lot of the reason people are participating is because they're now allowed to work with their physicians and get discounts on devices and things like that. But ultimately, you're right, it's like we need to actually bring down the cost of delivering healthcare, not just revenues paid by Medicare, but CMS is going to look primarily at what they pay, and then providers are going to look at their margin as a way to make these viable.
Just an example, we're implementing a project, in the Black Project, that's exactly in this area with a community hospice, and roughly speaking, they have no idea what their costs are. Yeah. So it's a big issue. They know exactly what they get paid across providers, and they know what the share of that is, and at some level, they've got some vague notion of overall, roughly speaking, is it working out or not? But we did some old-fashioned time and motion studies where we sent people to watch what people did, and it's interesting to feed that back, and they're kind of like, really, that's interesting. So cost is a very elusive concept.
Do we know anything about the association of participating in these ACOs and outcomes or actual quality?
Yeah, and I kind of didn't go over that in the presentation. I'd say the kind of the summary from the ACOs. So the ACOs, as part of their arrangement, they have, it's now up to, I think, 37 different quality measures. And overall, there's been kind of some, for the most part, quality measures have moved in the right direction. And the CMS has touted this quite a bit. I think that's all colored by the fact that, sort of, I guess, the state of science around quality measurement. There are a few process measures that are relatively easy to move. We don't really know how meaningful they are, or if we're just seeing changes in documentation. A lot of the outcome measures have more or less stayed the same. I mean, I think it's fair to say, and then, last week we had Dr. Owens and Dr. Bay kind of talk about quality within the health system, and I think there's broad recognition that we have all of these quality measures out there. At least as clinicians, a lot of us don't feel like that really captures, is really a good measurement of our quality. But yeah, I mean, overall, the summary is, yes, some of the process measures are moving in the right direction in small amounts. But at least in my personal opinion as a clinician, I'm not really impressed by the impact on quality. And that's not so much a knock on the ACO or on CMS, it's just the state of quality measurement.
So just to follow up on that, in light of the two comments that commented on the difficulty with measuring cost and your response that it's also difficult to measure quality, the problem is value is a function of those two variables. And our supposition here is that we're looking for high value care, but how do we define that if we can't define the two determinants?
Yeah. Well, I mean, it's certainly difficult to measure provider costs. I think it's very easy to measure what we're paying, what Medicare's total payments are. And that's why I kind of, sometimes it can almost seem uncomfortable as a clinician, why am I so worried about what we pay? Well, again, if we have to see drastic cuts to the program, I mean, that's, I think, almost unequivocally going to have, be a detriment. We know that many patients will not even be able to get kind of the basic level of care that they get today. So I think we can certainly see, measure kind of the denominator, the value equation from what is actually being paid out. But yet, I certainly have a lot of opinions of quality. I certainly recognize that I don't have the answers. Actually, I will note that last week CMS and a coalition of private health insurers released what they decided are sort of the standard, at least initial standard set of quality measures in an attempt to harmonize going forward. So they have it for primary care and a few other specialties. So they're kind of more of the same. But I think everybody, we all wish we had quality measures that everybody could agree upon. But I think, it's, in my opinion, it's okay to focus on the importance of the cost issue because it's necessary to the sustainability of the program.
That particularly in the literature over the last couple of years, there's emerged a body that really supports effective costing, particularly using time-driven, activity-based costing methods that have been used at a number of tertiary centers. I think the problem is not so much that there aren't ways to get costs, it's having the organizational will and the resources committed to do it. Currently, there are 4 people in the health system whose job is dedicated to cost accounting, and they basically just kind of keep the lights running for the most part. And so it's really, I think, a cultural decision that needs to be made to embrace and to invest in effective costing. The dividends will come downstream. But Duke is no different from most other places at this point, and it's an opportunity awaiting somebody to really seize on.
Yeah, and you need a couple of good examples, right? A couple of systems who employed the activity-based costing, and they were able to implement changes and see their profit margin go way up, and then people will adopt it. Right?
My question is more from sort of the data for research. The traditional health services research data looked at claims and in that fee-for-service sort of model. And it sounds like that with the accountable care evaluations, they're kind of running bundled payments at the same time as getting those claims and kind of reconciling them. Do you think over time this is going to change the either the granularity of the data, the type of data that we get for research purposes, and sort of where do you see that going? Because it seems to make a big shift, and maybe perhaps we're not going to be able to compare the same way. I mean, I think this is similar to being able to find out the details of what is actually happening if a lot of behavior or a lot of documenting is driven on, let's say, assuming that it has something to do with what you're getting paid for. How is this going to impact just later on?
Yeah, I mean, it's certainly, I mean, a lot, most of what's being done now is with claims data, and then the quality comes in, it's reported in that way. And certainly, I think there are probably people that could talk better than I about the potential of clinical data coming in through electronic health records and all that to improve our understanding. I think at least in the near term, the good news is I think there's a lot of good work to be done with claims data. We've kind of that's where a lot of my research is focused. I think there's a lot that we can understand, but we generally do understand it kind of at a higher level. So maybe we obviously we don't understand everything at the patient level to understand why things are different among patients. But again, looking at systems, to the extent that there aren't huge differences in the unmeasured variables, we can glean a lot of information across systems, or we can at least try to evaluate. So, like for example, what is Duke's performance compared to other ACOs with academic health centers? How do those compare versus comparing to other ACOs is kind of a indirect way to look at some of those differences. I mean, to my knowledge, I don't think as part of the ACO program, there's an effort at the moment to bring in more data that would be available through the traditional methods. But it's who knows.
A corollary to her question was, can you tell from claims data whether a patient was in an ACO or?
Yeah. Oh, yeah. Part of what's helping is actually Medicare has released as part of the program lists of patients who are aligned with ACOs. You can all. I mean, their methodology is public, so you could recreate it yourself. You need the list of ACO providers, but they are making that information public, which is what we're trying to take advantage of to enable a lot of this research.
There's a working paper by, I don't remember what LAN stands for, but a public policy group that reviews the different attribution methods for ACOs. And so part of it is a lot of it's passive, right? So people are in it, but they don't even know they're in it. So you could then decide, is it actually a thing? That's some of what the discussion's about.
And then kind of a bigger question. So a lot of these alternative payment methods seems like have led to maybe incremental change in the direction that we're looking for, but what do we think is in the pipeline that's going to be the big difference? There just doesn't really look to be anything that's going to make that big change, and we're just going to enroll more people and create more ACOs.
Well, yeah. Well, I mean, so now there's a lot of activity. Providers and payers are working together to design, new, better models. We'll see what comes of that. Personally, I think a lot of the potential is more unleashing the power of these current alternative payment models, understanding where the real opportunities are, maybe more so than designing a lot of novel types of alternative payment models. I mean, these kind of, we launched most of these programs in the first year of the Innovation Center back in 2011, and there haven't been I mentioned a couple others that are coming online now, but there haven't been too many other just big ideas out there that have surfaced.
Well, Bernie Sanders has one, and that's a single payer system. But that's probably a very separate conversation as an alternative to our current alternatives. But I want to thank you for a wonderful presentation and
Thank you.
great discussion by the group here. Thank you.